Hello, this is Rachel Williams from Maine Medical Center, and today we will be talking about the bedside focused right upper quadrant ultrasound performed by the ED physician. This is a study here at Maine Med, which is always followed by a formal radiology ultrasound. However, depending on where you work, it's possibly a study that you may be credentialed to do independently and use in your clinical decision making. So, for that reason, it is important to know how to perform it and how to interpret the images. The patient that you will do a bedside right upper quadrant ultrasound on is one that presents with right upper quadrant or epigastric pain. These patients will have a differential diagnosis that includes mainly biliary colic, acute cholecystitis, and gallstone pancreatitis. Gallstones are the common feature among these three diagnoses, and risk factors for gallstones include female gender, age over 40, obesity, rapid weight loss, TPN, family history of stones, and certain chronic diseases or medications. Briefly reviewing these diagnoses, biliary colic classically presents with right upper quadrant pain beginning shortly after a fatty meal. It may be associated with nausea or vomiting, and the pain may radiate to the right shoulder. This pain may resolve after 30 minutes to several hours, and patients may go days or months between attacks. Cholecystitis results from inflammation of the gallbladder caused by obstruction of the cystic duct. It may occur in the presence or absence of a superinfection. These patients appear more ill and have a fever, and they have a hard time taking deep breaths. Their exam will have more marked right upper quadrant tenderness with guarding, and often a positive Murphy sign. It is usually associated with gallstones, however, may also be a calculus. Pancreatitis often manifests as severe upper abdominal pain that may radiate to the back. It's usually a constant pain and made worse by laying back and relieved by sitting forward. These patients often have nausea and vomiting, and fever and anorexia are possible. The abdominal exam often demonstrates a soft but tender abdomen, usually in the epigastrium. Guarding or rebound suggests a more severe disease, and they may also have abdominal distension that is secondary to an associated ileus. So when performing this ultrasound, you want to remember the questions that you're going to ask. Mainly are there gallstones, and is there a sonographic Murphy sign? Things we also look for and questions we also ask include, is the common bile duct dilated? Is there pericholecystic fluid? And is the interior gallbladder wall thickened? However, the two questions that are on the left-hand side of the screen are really the main ones that we in the ED can ask and are better at assessing. So reviewing the anatomy of the gallbladder before looking at the images. The gallbladder sits beneath the liver, and the gallbladder itself is not a fixed organ, so it can move to a variety of locations within the right upper quadrant. The gallbladder connects to the common bile duct via the cystic duct, and the common bile duct can be found conveniently clustered with the portal vein and the hepatic artery. The gallbladder neck has a fixed relationship to the main lobar fissure and the portal vein. The main lobar fissure connects the portal vein to the gallbladder neck, and the fissure can be traced between the two. In this image, you can see the relationship of the gallbladder, which is labeled G, and the portal vein, which has the asterisk, with the bright white main lobar fissure beneath the arrow. Another reliable anatomic relationship is that the bile duct is always anterior to the portal vein. These ducts appear to have brighter, more echogenic walls than the veins or arteries on ultrasound, and this is because they are more fibrous and thicker than the thin walls of the portal vessels and the hepatic veins. When scanning the gallbladder, the curvilinear or abdominal probe with a curved footprint is most commonly used. Occasionally, a microconvex or phased-away probe with a smaller footprint can be used, especially for those gallbladders that are located posterior to the ribs. The frequency range for both of these probes is between 2.5 and 5 megahertz. During this exam, the patient is going to be lying supine, However, the left lateral decubitus or upright sitting positions can be useful in difficult cases, as this brings the gallbladder closer to the anterior abdominal wall in the probe. To find the gallbladder, place the probe under the right costal margin as shown here, with the marker dot directed towards the patient's right shoulder or the patient's head. Sweep along the costal margin until an image of the gallbladder is found. If you're having trouble, you can have the patient take and hold a deep breath to bring the gallbladder down below the rib margin. If you continue to have trouble, you can place the patient in the left lateral decubitus position, as mentioned before. Another approach is to hold the probe in a transverse view with the marker dot towards the patient's right, and usually this is in the midclavicular line. The probe is then tilted cephalad and caudad to find the gallbladder. It's useful for the patient, again, to take and hold a deep breath to displace the gallbladder below the ribs. Sometimes, if you're still having difficulty, you can put the probe above the costal margin to use a liver as a window and avoid the bowel gas. When looking through the ribs, it is often useful to use the smaller probe with a smaller footprint. So now that we've grossly identified the gallbladder, let's talk about the normal ultrasound images and which images are necessary to obtain for an adequate study. It's also important to be very familiar with these normal images so that we can later identify gallbladder pathology. So this first clip demonstrates the gallbladder in a longitudinal view. Once this view is obtained, you want to try to demonstrate the relationship of the gallbladder with the portal triad. So with this long axis view of the gallbladder, the main lobar fissure and the right portal vein can be seen, with the bright white lobar fissure connecting the two. Obtaining this view, you see the appearance of an exclamation point, as shown in this clip. This confirms that the structure that you're looking at is indeed the gallbladder and not a loop of bowel or the IVC. With a view of this characteristic exclamation point, gentle manipulation can reveal the common bile duct, the two bright hyperechoic lines anterior to the portal vein. Remember that the common bile duct always lies anterior to the portal vein. In some cases, the common bile duct and hepatic artery can be distinguished using the color flow Doppler. This can be helpful because the hepatic artery and portal vein will light up, showing blood flow within, while the common bile duct will remain dark as it lacks blood flow. You then want to scan the gallbladder in multiple longitudinal and transverse planes, and it is important to fan all the way through in both of these planes to ensure that you are not missing any stones. Then, with the gallbladder in view, you attempt to compress the fundus to assess for the presence or absence of a sonographic Murphy sign, which is the most specific sign of inflammation. The challenge is to make sure that you are below the costal margin so that the probe pressure directly compresses the fundus to the gallbladder and is not pushing onto the ribs. Again, in this view, you can see that exclamation point, which is the gallbladder, the main lobar fissure, and the portal vein. There are two measurements made during this ultrasound, and those are of the anterior gallbladder wall and the common bile duct. An abnormally thick wall suggests inflammation and is often present in acute cholecystitis. However, it is a nonspecific finding, and many other pathologies, as well as a postprandial gallbladder, can give you a falsely elevated measurement. The differential for a thickened gallbladder wall includes renal failure, ascites, hepatitis, multiple myeloma, cholecystitis, and even heart failure. As shown in this image, the gallbladder wall is measured via the calipers labeled A, and it is 3 millimeters. This is a normal measurement, and anything measuring greater than 3 millimeters is considered abnormal. The easiest way to measure the gallbladder wall is to decrease your depth so the anterior wall is the prominent feature on the screen. Freeze, and then measure. It's important that you measure the wall of the anterior gallbladder because of the acoustic enhancement artifact that occurs off the posterior wall, as shown in this image. Posterior acoustic enhancement is artificial brightness deep to an anechoic structure, as shown here. Because of this, the borders of the posterior wall are difficult to define and can produce an artificial measurement, and therefore only the anterior wall should be used to measure the thickness. This image brings us to our next measurement as well, which is the common bile duct. It is measured from interior wall to interior wall. A common bile duct that is dilated suggests obstruction, and this is the second measurement required for a complete evaluation of the gallbladder. The common bile duct is typically less than 6 millimeters in the transverse diameter. This diameter can increase normally with age, and some have recommended that the diameter should be less than 1/10 of the patient's age. Another common method to determine normal is to add 1 millimeter per decade over 60 years old. For example, 7 millimeters may be a normal measurement in a 70-year-old patient. Here's another example of a normal common bile duct, which measures 2.7 millimeters. As you see, the structure is small, so it's important to have the appropriate depth on your probe to obtain the most accurate measurement. Now that we've defined normal structure and measurements, let's talk about the abnormal images that you might find in a patient with real pathology. As mentioned earlier, the abnormal things that we are looking for include gallstones, a sonographic Murphy's, as well as pericholecystic fluid, gallbladder wall thickening, and common bile duct dilation. This clip shows a large gallstone. Gallstones appear as echogenic foci with acoustic shadowing. The acoustic shadow leads to a loss of signal penetration distal to air or bone, as demonstrated by this gallstone, and the shadow will extend all the way to the far end of the screen. Shadowing may be absent in gallstones that are small and less than 4 millimeters in diameter. Most gallstones will layer in the dependent portion of the gallbladder and will move when the patient is repositioned, unless they are impacted or of high cholesterol content. This clip shows multiple gallstones, again in the dependent portion of the gallbladder, and they also have this characteristic shadowing, which extends all the way to the edge of the image. Sometimes no stones are seen, and rather only sludge, as you can see here in this still image where the asterisk is in the middle of the gallbladder. Biliary sludge may be detected as a dependent layer of variable shadowing in the gallbladder. It's frequently found in states associated with biliary stasis, such as limited oral intake, and it has also been known to cause biliary obstruction as well as cholecystitis. One distinct finding to note is the wall echo shadow sign, or the WES sign, which can be seen in gallstone-filled gallbladders. It is characterized by the following: an anterior echogenic line within the near wall of the gallbladder, an echogenic stripe representing bile, and a hyperechoic line representing stone. So in this clip, you can't really define the borders of the gallbladder because it is so full of stone, and it has all of these defining features of the WES sign. This next image demonstrates one of the defining features of cholecystitis, which is pericholecystic fluid. This is seen as hypoechoic fluid outside of the gallbladder wall and is related to the inflammatory process. This clip also shows pericholecystic fluid and has the additional finding of a gallstone. In contrast to the normally measuring anterior wall seen earlier in this presentation, this clip, or this still image, demonstrates a thickened gallbladder wall. Although the measurement is not on the screen, you can see even with your eye that it looks much thicker than the previous images. If we are lucky, a patient with cholecystitis will demonstrate multiple abnormal findings to solidify the diagnosis as shown here. This image has multiple gallstones, a thickened gallbladder wall, as well as pericholecystic fluid. Here's a clip demonstrating more of the same with gallstones, pericholecystic fluid, and a thickened gallbladder wall. And here is yet another example of acute cholecystitis. You can imagine that if you see this on bedside ultrasound, your workup now becomes much more streamlined as you have a diagnosis made. Remember that at Maine Medical Center, at least at this point in 2015, a confirmatory study done by radiology is always required. However, this is not the case at many other facilities and may not be the case at Maine Med in the future. So it's important to learn the skill and be able to identify such pathology. When trying to identify gallbladder structures and common abnormalities, it's important to know what else may be in the ultrasound image that may mimic some of our typical pathologic findings. The following examples often fake us out, much like Lucy faked out Charlie Brown with football on more than one occasion. A polyp, as seen in this slide, noted by the large white arrow, is a common fake out for a gallstone. Note that polyps should not create acoustic shadows, and they do not move as the patient moves. Changing position will cause gravity to act on gallstones, whereas polyps remain fixed in position. Although the lack of gallstones may be reassuring in a patient with acute abdominal pain, remember that polyps may represent malignancy and require follow-up, regardless of the acute clinical course. When looking at this next clip, at first glance, it may appear that there's a large stone or multiple stones within the gallbladder. However, looking more closely, what the eye initially thinks is a stone is actually outside of the gallbladder wall and is, in fact, the duodenum. The duodenum is often mistaken for the gallbladder by the novice sonographer. Since a normal duodenum can appear similar to an abnormal gallbladder, it's important to distinguish. The gallbladder wall is fibrous and typically acts as a bright reflector. Even in the setting of wall edema with cholecystitis, there are bright areas of wall between the areas of edema. However, the wall of the duodenum is dark, like most bowel wall. Additionally, the duodenum courses near the liver, but is never surrounded by it like the gallbladder. Also, observing the gallbladder over time should reveal peristalsis, which will not occur with the gallbladder. And lastly, the gallbladder is finite, and clear boundaries can be visualized by scanning through from top to bottom and left to right. In contrast, the duodenum leads to the stomach proximally and the jejunum distally. So how does this test perform? Well, initial studies in the 1980s suggest that the finding of gallstones and a sonographic Murphy sign on ultrasound have a positive predictive value in the area of 92% for diagnosing cholecystitis. However, this study did not focus on ED physicians performing ultrasounds. Rather, these were formal ultrasounds performed in the radiology department. In these studies, negative findings, so no stones, no sonographic Murphys, were associated with a negative predictive value in the 95% range. This is the background literature to support the goal-directed study of the right upper quadrant with ultrasound. Recent studies that have looked at how ED physicians perform suggest that we are really good at finding stones. With limited training, the emergency department physician can identify stones, and we are also fairly good at the sonographic Murphys. However, the more subtle features of cholecystitis, such as pericholecystic fluid and common bile duct dilation, are things that leave room for improvement. However, if you see these findings, you should comment on them, and you should practice looking for them in all of your bedside ultrasounds so that you may improve your skills and improve your clinical decision making. So what are the next steps? Practice. Get really good at finding the gallbladder, looking at the normal anatomy, and identifying pathologic findings that we discussed here. Remember to save all your images so Pete and Dave can help us improve our skills, and remember to log all of your scans for credentialing in the future. On this slide, you'll find my references used to make this presentation, and I want to thank Pete Croft and Dave McKenzie for their assistance. Thanks, and happy scanning.